So I'm going to talk to you how we do PFC sigma RPF knee. Our goal is to perform a total knee with my word is reduced tissue trauma surgery. I don't particularly aim for a small incision. I use as large incision as possible to do a good operation. And pain control and early motion and early weight bearing. So those are my three key words. So I don't use tourniquet until I'm ready for cementation, and sometimes sooner. Our average tourniquet time is around 20 minutes to 22 minutes. Avoid cutting quadriceps muscle, I'll show you what I mean. And retraction of soft tissue by angle Homan, as you just saw. Preserve the suprapatellar pouch. Avoid damage to the anterior aspect of the femur. And spinal anesthesia and a mean pressure, mean arterial pressure around 55 to 60. Steps. When you flex the knee to 110 degrees, it doesn't bleed. An incision from tibial tubercle to a 3-finger above the superior pole of the patella. With that length, you can expose any knee. Flex the knee, undermine the medial flap only, and mark with methylene blue so that you can align it properly. Identify the lateral genicular and coagulate it. Evert the patella just to excise the tibia and the patella, and then you put on the side. And as I said this morning, size the tibia from the lateral tibial condyle surface and reduce the medial tibial plateau equal to the lateral tibial plateau, and judge the cut, that your cut is 90 degrees. That's my navigation. Put the tibial base plate in a rod. A rod should be in the middle of the tibia. So you have a within 1-2 degrees of neutral position. Enter the femoral canal, cut the distal femur 9 to 10 millimeter on uninvolved side. This is true for both tibia and the femur. So your gap is about 20 millimeter. And a little less if you have a bad deformities. So extension gap of 20, balance it in extension as I'm showing with lamina spreader, and I'll do appropriate lengthening of the medial structure in a varus knee and lateral side in the valgus knee. This is important. I measure the height of the femoral condyles from the anterior surface, so anterior referencing, and I try to restore the posterior offset of the femur. And posterior condylar cut parallel to the tibial cut, assuming that the knee is balanced and assuming that your cut is 90 degrees. And here I'm showing how I do it. And lateralize the femur. You can do it with a PS knee, you cannot do with a CR knee. So this is what I'm showing, how much I will lateralize it. When you lateralize the tibia, lateralize the femur, rotate it properly, you don't need to do any lateral releases. So after cutting the anterior surface, I have a block, 6-in-1, which I put and cut it, put the trial test, the stability, and this is a spin-out test for RP and RPF knee I have described, that with this position, you flex, extend the knee and torque medial lateral. If it doesn't spit out, you are balanced in flexion. And cement on both sides and pressurize it as shown here. And put the suture in flexion and tie in extension and close the dermis well, because that decides how wide the scar will be. Video please.
And the incision I make is
so now you'll see
from the tibial
real,
tubercle, which is
all
here,
these steps in a
and
video.
straight incision.
Knee flex, filling the tibial tubercle, you mark it, and a straight incision. Okay, I got it. And I deliver the tibia in front, as you could see. I'm marking the lateral tibial plateau. I'll see what fits in there, and this is the extra bone. I mark it and I'll take it down. Evert the patella and excise it. I'll talk more about it to the floor of the lateral facet. You can use a single peg or 3-peg patella. This point is at the junction of the patellofemoral articulation to tibiofemoral articulation, and draw a line, and just touching that line is the center of the canal. I cut the trochlear groove first, so I have a flat surface. That's just a provisional cut. Then I'll put the distal femoral cutting block and then cut the 10 millimeter on the lateral tibial, lateral femoral condyle in a varus knee. And put the block, and I'll test whether the knee is balanced or not. If it's not balanced, I'll balance it. And then put a femoral cutting block and rotate it in a manner so that this is parallel to this, with the lamina spreader in place. Which you are going to see now. And if it is not, I'll move it up and down, or rotate it and get it this space rectangular. And then test it whether your rotation is correct, and then lateralize the femur as I pointed out. Cut the box, remove the posterior osteophyte, and a little bit more bone you remove here for RPF. And I'm showing the rotation of this is such that this rod is in the middle of the tibia. Keel preparation. Put the trial 10 millimeter, and I will then test whether the knee is in full extension, whether the soft tissue balance is medial lateral is correct, and the patella is tracking properly, and see the full range of motion, which you didn't appreciate. And here I'm injecting the cocktail and cementing the tibia first, femur next, especially the posterior condyle. Extend the knee and pressurize it. All right. And you see that the patella is touching both condyle and full flexion. You could see that. That's why I tested. And you align the quad, and you close the skin and subcu and approximate the dermis. Thank you.